Hello, I'm Matt Davids from Dana-Farber Cancer Institute in Boston.
And hi, I'm Wierda from the MD Anderson Cancer Center in Houston, Texas.
And we're very happy to be with you to discuss an abstract from MD Anderson, abstract 3723, Venetoclax consolidation in patients with high-risk CLL who've been on Ibrutinib for more than a year. And they show that this achieved a high rate of undetectable MRD. So we do have a lot of patients out there now who are on BTK inhibitor drugs. Many of them are doing well, but some of them are having issues with side effects and other issues. So certainly interesting to try to add something in, perhaps to deepen response and get patients off therapy. So Bill, maybe tell us a little bit about the rationale and the study design here.
Sure. So this is a trial that we initiated several years ago based on the concept of an ability to consolidate or deepen remission so that we're comfortable with getting patients off treatment based on an undetectable MRD status with an expectation of a long treatment-free interval in remission. As you know, BTK inhibitors don't necessarily achieve deep remissions in most of the patients to the point where we're comfortable with taking patients off treatment. And so this was a trial that we developed as a strategy to achieve that using Venetoclax. We know for patients who are on Ibrutinib or other irreversible inhibitors of BTK, acalabrutinib and zanubrutinib, persistent disease is usually in the form of residual disease in the bone marrow and or in the blood. Those BTK inhibitors are highly effective at reducing lymph node size and eliminating lymphadenopathy. But it's a little, the persistent disease is usually present in the blood and the bone marrow. And Venetoclax, as we have seen, is highly effective at inducing apoptosis, clearing blood and bone marrow of disease. So this strategy was taking advantage of the complementary clinical activity of these agents. And we also had done some work with combined Ibrutinib Venetoclax and demonstrated safety with that combination. And other trials, as we've talked about, have looked at that combination, have demonstrated safety. So we intended to look at the combination or consolidation in high-risk patients. Patients that we identified as high-risk were those patients with 17p deletion or mutated TP53, 11q deletion, complex karyotype, or high beta-2 microglobulin. Patients had to be on Ibrutinib for at least a year or longer and have measurable residual disease, either by MRD in bone marrow or persistent adenopathy, etc. The initial trial that we enrolled 45 high-risk patients. Patients received up to 24 cycles of combined therapy. So we added the Venetoclax with a standard ramp-up and then continued it for a total of 24 cycles of combined therapy. And we looked at serial MRD and IWCLL response. And so Philip presented this data, I think last year or the year before last. And then this year at ASH, in the poster, we presented the updated data for all 45 patients. What we've seen is not surprising, and that is that patients do achieve an undetectable MRD state with addition of Venetoclax. In general, it looks like about 50% of them will convert with each year of therapy. So all the patients had measurable disease at enrollment. 50%, 57%, I believe, actually had converted to undetectable MRD state at the end of 1 year of combined therapy. And then an additional 50% of those converted with the second year of treatment. So the overall undetectable MRD status is about 75% for patients at the 2-year time point that we have with the follow-up that we have. So it's well-tolerated treatment. We see consolidation, and many of those patients have gone off treatment. This trial continues in terms of follow-up and treatment for those patients in the initial cohort of 45. We also modified the protocol to enroll an additional 45 patients but those patients had to have 17p deletion or mutated TP53. So the high risk group was sort of focused on 17p mutated TP53, and that modified cohort is currently enrolling. So we're encouraged with these results. One might ask if there's benefit with the addition of CD20 antibody as well. And I think those are all that and other questions arise with this strategy. But I'm very optimistic with this in terms of a strategy of consolidating patients, getting patients in deep remission so that they can come off treatment with an expectation of a durable, long-lasting remission.
Fantastic data. And I wonder also if these data could be applied or extrapolated to a lower risk population as well, who might also be interested in coming off therapy. Certainly in the trial setting, it makes sense to focus on the high risk patients, but this could be broadly applicable.
Absolutely. So as you mentioned, when we initially developed the study, we were focused on high risk because those are patients that we felt we could demonstrate benefit to. But as you know, patients with a mutated immunoglobulin gene those patients with a mutated immunoglobulin gene experience very long remissions if you can get them in the deep remission and undetectable. And I'm optimistic that we'll likely see patients in that group cured with this type of therapy as we did with FCR in the era of chemoimmunotherapy. We just don't have those data yet.
All very exciting and great to have these new options and new approaches to therapy coming along for CLL patients. So thank you very much, Bill, for a great overview and providing your insights. And thank you all for watching.
Thank you, Matt.
All right. Thanks, Bill. Good to see you.
Okay.
Yeah.
Good to see you.